Hello, I'm Dr. John Kruse, and today's question and answer session is based on the video I released a few days ago. What is ADHD? So, after a one or two, and I think I'll be brief today, summary, I'll be open for questions, and the questions can be on that video. They can be on other ADHD topics or other mental health topics as well. So, to launch right into the quick summary, ADHD is defined by our DSM, our Diagnostic Statistical Manual, consists of 9 inattentive and 9 impulsive hyperactive possible symptoms. You only need, as an adult, 5 of those symptoms. Those are things you have to be displaying since early childhood. Formerly, it was before age 5. Since recollection is poor, the cutoff now is you have to have them since before age 12. And what's important, because all of these behaviors are normal human behaviors, is that they are carried out to such an extent and such frequency in enough different situations that are causing distress or dysfunction. I won't go into those 18 points right now, but most of the online checklists, particularly the ones that have 18 questions that I ask you, are following point by point. The DSM list is certainly not the most helpful mapping onto ADHD. So aspects such as emotional regulation, such as time management, a few other topics are completely omitted from the DSM. And there's a lot of overlap between the questions that are asked. Most of those questions were initially, they all were designed to be testing a child population, and some of them do need to be addressed or stretched or manipulated to apply more helpfully to an adult population. Um, but more recently, rather than a checklist of symptoms, we tend to think about ADHD as a collection of executive functions, which are primarily based in the frontal cortex up there, that are not behaving as they do in adults without ADHD. So, executive functions things include things like selective attention, working memory, ability to prioritize, to plan, to inhibit immediate responses, to regulate emotions. And one important question, and it's one that there was some sort of feedback and pushback even on the question and answer in the comment section on the video. Clearly, ADHD symptoms exist along a spectrum of severity. So you can have a number of symptoms that can be severe. There does not seem to be, there seems to be a continuity in terms of number of symptoms and severity of symptoms, ranging from almost none to robustly. But whether or not that actually captures, I mean, so one, if it is on a spectrum, it's somewhat arbitrary where we decide, is it really 5 symptoms you need? Is it 6? Is it 7? Is it only 2 if they're the right 2? Um, and there's certainly many individuals with ADHD who feel categorically that their brain is different than most people's, and many of them push back against the idea of this being on a spectrum. But I would say so far, we are not finding some separate identifiable biological marker that is distinct just for the population with ADHD and isn't found in others. And there's some, the cumulative evidence for each individual situation, maybe not, but the cumulative evidence is whether you are getting ADHD symptoms from head trauma or from strong genetic family history, having it from birth, or from post COVID symptoms, or from um, some other cause arising or early signs of dementia, they all seem to be affecting those same prefrontal cortices. And there does seem to be some commonality of functional circuitry in the brain that is impaired. Um, so I will stop right there. I do hopefully when a few more people have signed on, I do have a question about timing of these Q&A. I'll throw it out now, and hopefully I'll remember to ask again at the end. Um, there's some potential issue that to optimize potential audiences, I should move these Q&A sessions on Tuesdays maybe 2 hours earlier, maybe even 4 hours earlier. So if any of you have strong feelings, I know I'm speaking to the audience that happens to be here right at this time, but if there are strong feelings for or against moving it 2 hours earlier or even 4 hours earlier, let me know. So that being said, I see a question from Dennis. So Dennis asks, should ADHD screening involve a sleep study? So a good question. So I will frame it that 90% of what they are finding and looking for on sleep studies is sleep apnea. That's far and away the most common condition. It's a condition that can be um, diagnosed clearly and distinctively from a formal sleep study, which involves EEGs attached to the skull to measure brain activity, as well as measures of breathing, sometimes measures of chest expansion, measures of peripheral muscle activity, usually body temperature, heart rate, blood pressure as well. And sleep apnea can cause an ADHD picture. It can make an someone with ADHD, it can further impair executive functions in the frontal cortex. So if sleep is a prominent part of what's going on, then it certainly could be useful information. Given that upwards of 85-90% of people with ADHD have abnormal sleep, I would argue that that actually diminishes the value usually of getting a sleep study because we already know your sleep is likely to be impaired, particularly less consistent bedtime, particularly delayed sleep onset and trouble falling asleep. Um, so often a formal testing may not offer much more than you already know. Yeah, your sleep is weird or delayed or off. Um, so in some ways, my basic philosophy is against over medicalizing and over performing expensive tests, which the test administrators get lots and lots of money for. And again, if it's going to provide or likely to provide useful information, great. And again, particularly if you are feeling groggy from the time you get up, if sleep doesn't seem restorative, if there have been changes in sleep that mirror changes or decrements in daily functioning or exacerbation of ADD symptoms, those are all good or compelling reasons. But I would say that right now, I don't see generically suggesting that everyone with ADHD get a sleep study is likely to be a cost effective intervention. So So Jonathan Carpenter says, "Hello, how are you? I'm pretty good today, thanks. Although we maybe, hopefully, I will be better at the end of the day when we have some election results in. We will see." So Jonathan Carpenter asks, "Can he text or email me?" So my email is on the website and I'm connected to most of these or on this channel. So Dr. John Kruse, all mushed together as one word at gmail.com. It's fine to ask questions. Hopefully, you're comfortable to ask questions here. And it's likely that everyone will be informed or educated. I appreciate there may be more personal information. The other thing I'd let people know is that even though, yes, I am a medical doctor, a psychiatrist, right now I am providing general information. So I don't have a doctor patient relationship with any of you. I don't have, you know, I'm trying to answer informational questions and not make diagnostic issues or specific medication recommendations because I simply wouldn't have enough context pertinent information to make those ethically or accurately or helpfully. And in parallel with that, I'm actually not looking for any new clinical worker patients. I'm trying to spend more time with the YouTube channel and the writing. So but you're certainly welcome to contact me or mention your questions here. Um, Colin also says hi. So Antaretsa Magome is back again, and they say they are struggling with insomnia. On 20 milligrams Ritalin long acting, take it over 16 hours before bedtime. Any suggestions? Many people are on Seroquel and olanzapine for sleep. Um, so one, and this is strange, but I've certainly seen a number of people who just shifting, taking a long-acting form of a stimulant by an hour or two often gets what seems to be many more hours at the end of the day where it's easier to fall asleep, or a minor shift seems to produce. I'll back up even further. The presumption is that you're present in your body that hasn't been cleared or degraded, that it is activating your arousal systems. One of the biggest findings of sleep medicine in the last 20 years is that virtually everyone with insomnia has an intact, completely normally functioning sleep system. Huh? How can they have insomnia? And I have talks about this. What they have 95 plus percent of the time is failure of the daytime arousal system to shut off. So the sleep is sitting there, it's waiting to get in, it's waiting for a soft landing place, but it won't enter if daytime arousal is too high. Um, and certainly drugs that work on ADHD, most of them rev up the sympathetic nervous system, activate or cause release of dopamine or epinephrine. So it certainly makes sense that too much Ritalin left over at the end of the day could interfere with sleep. So my two starting points is always to do less or to reduce. One might be trying to see if 15 milligrams of long acting Ritalin has that same effect, or hopefully it could give you the benefits during the day without disrupting sleep. Two is, as I started to say before I interrupted myself, I have lots of people who moved their drug use, not pharmaceutical medication use, to an hour earlier in the day. And often that had a tremendous impact on sleep. And for those who are taking it right when they get up, I've had many people who set an alarm for an hour before they're going to wake up, take their pill. So they have the pill by the bedside, they have a glass of water by their bedside, they take it, they swallow it with water, they go back to sleep. And most people, not everyone, but most people with ADHD can sleep well for the first hour of a long acting stimulant going into their body. And then, two advantages. One, when they wake up, they are more fully, the drug is more fully entering their system and they feel they have a faster start to the day. And two, decreased amount left at the end of the day. So specifically, Resta asked about Seroquel or olanzapine. I talk a little bit about those. I've talked on antipsychotic medication. So both of those are what we consider to be atypical antipsychotics. They do have some dopamine blocking properties and also effects on serotonin 2A systems as well as others. These two tend to be highly sedating. They have high risk for metabolic effects, so people gaining weight, people having disruptions in sugar and fat metabolism, even if they don't gain weight. They do increase the risk for long term movement disorders, even though the risk with them is clearly lower than it is with the first generation antipsychotics. So neither of those would be anywhere close to what I would encourage anyone to start with for sleep. So I do have a separate talk on orexins, dual orexin receptor antagonist, DORA drugs, medicines like Belsomra. On paper and neuroscientifically and conceptually, they seem to be the ideal sleep agents in that they are um, shutting down that daytime activation system or turning it off rather than just pushing on sleep more. Again, if your sleep system is intact, almost all of our sedating sleep medications are just banging further on the sleep button. And yes, if you sedate someone enough, they will fall asleep. It works, but If the sleep system wasn't even the part of the system that was broken or aberrant, why would you push harder on that pill? So I should back up a step further. I do have a talk on um, cyclic sighing specifically for sleep. Um, the literature is pretty compelling that all of our sleep agents, some of them work faster in the first days or weeks, are more effective than cognitive behavioral for their CBT for sleep approaches. But the longer you try and the longer you work with CBT, the bigger the effect is. Whereas with almost all of our sedating medications, their effects diminish with time. Some people need them. Some people can't get good sleep without them. Getting good sleep is absolutely better than having miserable sleep. Um, but I would put Seroquel and olanzapine. So if I had to hierarchically rank things, I would put DORA agents. One, I would put non-medication approaches for sleep. Two, I would start with DORA agents, maybe melatonin, maybe trazodone. Even there's some suggestive studies that suggest low dose trazodone may even have preventive effects against dementia later in life. That's not nailed down yet. Um, I would certainly put the partial benzodiazepine agents, the Z drugs, things like zolpidem, Ambien, zolpiclone, um, Lunesta, Sonata, ahead of the pure benzodiazepines, so things like Restoril, Temazepine, um, Serax. I'm not remembering the other names. Lots of Valium and Ativan and Xanax are also used for sleep. Those are clearly at the bottom of the list, and I would put also at the bottom of the list the antipsychotics and the barbiturates, which we hardly ever use at all now because they're dangerous in overdose. And I should point out, if I'm over talking this one, that some of the dangers and risks and side effects I've talked about with Seroquel and olanzapine are present at dosages that are used for schizophrenia and um, bipolar disorder. We don't know how much lower those side effects and problems may be at the low doses. Many people use those medications for sleep. And I would say, given the seriousness of those side effects and given the frequency with which those whole class of drugs are being used for a whole variety of symptoms, it's, I would say, verging on negligence or criminality that we don't have more hard evidence of what are the real relative risks at the lower dose end of those medications. So, Scooties Z 1983, hi. Said we hear a lot about dopamine with respect to ADHD, but we also hear about glutamate, also norepinephrine, serotonin. Could you do a talk on demystifying all the chemicals and neurotransmitters? My flippant answer to that is we don't even know if we've discovered them all yet. So particularly the first wave of interest in neurotransmitters, so I'll give a really condensed version, starting in the 50s and 60s, and Carlson in Sweden was one of the early neuroscientist researchers who led us in this direction. It's a good started investigating the monoamines, so chemically somewhat related norepinephrine, serotonin, and dopamine systems that are tremendously powerful systems. They are starting in tiny brain centers at the base of the brain and spreading their axons, reaching and ramifying to all sorts of different regions of the brain. But numerically, each of these are tiny, tiny systems. So there's so much talk about dopamine and serotonin and norepinephrine. Each of them represents less than 1% of the neurons in their brain. They are tiny systems. Doesn't mean they're not important. Glutamate, on the other hand, is the opposite extreme. More than half the neurons in the brain seem to use glutamate. It's the most common excitatory neurotransmitter. It's the most common neurotransmitter overall. So, at some level, I mean, almost any pathway in the brain at some point, this is an over exaggeration, is using glutamate. Um, so, I do have a talk somewhere back in there. I think it may be more dopamine focused, but sort of uh, one of my pet peeves is sort of a little science can be a dangerous thing. I have, people coming in saying, "Oh, I could tell my dopamine was low because I felt this or that or didn't feel this or that." And almost certainly they are not feeling or responding to dopamine. So I think we tend to sort of propagate myths that oversimplify. So it's a good subject, and maybe giving an overarching talk, an expansion of what I just started. Um, I'm writing it down so I don't forget. I know it's written here in the. So Colin mentioned that my audio is fading in and out a little. I had a patient mentioning that, so I don't know if it's just moving closer and farther as I'm talking. We've been trying to optimize the sound. The microphone is right here. So I will try to move around less and talk more loudly and clearly. But thanks for the feedback. So Borislav Litvinov says, greetings. Please check your mic. Your speech spikes. I may actually move it a little further away. So I did change both the gain and the noise canceling because we thought that was a problem. So I may have overpushed it. So Music Merce says, hi, Dr. Kruse. Can untreated ADHD lead to unspecified psychosis? So I do have a talk on two different aspects of psychosis. I believe I have talks on both of them. I know I have a talk on amphetamine-induced psychosis. So it's a rare but really serious and I believe under discussed and addressed aspect. But there's also, and I believe I do have a talk on an older one in this channel about ADHD and psychosis itself. So the risk of developing a psychotic disorder and a schizophrenic-like condition is elevated just by having childhood ADHD. Probably some of that risk is just having a bunch of versions of hundreds, if not thousands, of genes that are the bad version and predispose someone to a number of different psychiatric conditions. Um, the one of the worries is in someone who might be vulnerable, specifically both to ADHD and to psychosis, is treatment with stimulants, which is pushing or flooding or increasing, particularly dopamine tone, a bad or a dangerous thing? Um, so, yeah, so I don't know that I don't believe we have any data whatsoever to suggest that that not treating the ADHD will increase someone's risk. Again, there is and it's not a huge risk, but it's a measurable risk. Again, just having ADHD, you are more likely at some point in your life to develop a psychotic disorder. Again, it's a relative risk. It's still a quite unlikely outcome. But I don't know any evidence, and I would think on a neuroscience basis that treating ADHD, even though it helps with lots of other things, may not treat or lower your risk there. So I see some other comments about the sound. If it's still a problem, let me know. The other issue related to sound is I work from rural Hawaii. I am on Starlink, the satellite system. Elon Musk should be spending a little more time on his real work rather than dabbling in politics and destroying Twitter. I mean, I think actually destroying Twitter is one of the good things he's done for humanity. Anyway, so there might be specific sound issues. It may just be a connectivity issue, which is not uncommon. And that one I can't do anything about. There are no other options here for internet. So Laban says hi. So Laban scored high on a screening, I'm presuming for ADHD, worried that I will be refused. because of a lack of being classroom disruptive as a child. Should I be worried? Um, my flippant answer is if you're going to someone who is that unaware of ADHD that they say you can't have it just because you weren't disruptive in the classroom, then you should be worried that you're going to that person because that shows, not too much knowledge or awareness about ADHD. So again, people can score high on a screening because they have ADHD. They can score high on a screening because they have anxiety going on, because they have depression, because they have a whole bunch of additional reasons can cause high scoring on a screening tool. A screening tool is not a diagnostic test. It's designed to say, hmm, this group of people needs a closer evaluation. And a closer evaluation absolutely should include a history going back to how you behaved as a child. But classroom disruption, it would be one contributing factor if it's found, but if it's not there, I mean, maybe you're the kid who is zoning out and daydreaming out the world. Probably okay with the teachers, probably okay with the kids around you, wasn't disrupting anyone. Um, or maybe you were the intelligent kid who was not turning in their homework, but not disruptive, but were bright enough that, they passed the tests, they did enough of the homework or in class participation that nobody detected their ADHD at that stage. So again, screening tool is helpful and useful. Hopefully, it's a lead in, particularly to the items you scored high on, to find out more about the context, the situation these that's problematic for you. What are the areas that have not been a problem for you? Um, assessing the realms of inattentiveness and other executive functions, but also impulsiveness, also hyperactivity, and putting it all together. So I'm actually going to, if I can, doesn't look like I can. So I'm getting feedback that the sound is the issue, and I am slowly bringing up that, and maybe I'll reset it mid-stream and see if that helps. Sorry for the delay. So I am moving up the gain from 21 to 30, and I am putting the noise reduction up a little higher, lower. That one I'll just leave right now. The other factor that could be affecting the acoustics is I have left the door open. I didn't want the dog to be scratching to be let in, and there's no one else in the house right now. Almost every other time the door's been closed, that may be affecting the acoustics as well. So again, I will try to talk clearly and loudly. Someone's echoing my sentiments about Musk. I'm trying not to go too far into politics, but so Laban clarified that the GP he or she, they saw, said I probably don't have it because I wasn't diagnosed as a child or disruptive. Maybe change the GP. Again, there's lots of, I mean, might be if you're feeling rich or generous, I mean, you could buy them a book about ADHD that informs them more, or maybe less expensively refer them to a good YouTube channel or video that describes ADHD and makes it clear. Again, if you had been disruptive, not that that's the only source of disruption, that would be supportive evidence. Not being diagnosed as a child, again, particularly rates of diagnoses vary tremendously across with geographical variance and within this country. They vary country to country. They certainly vary even within regions of the country, from urban to rural areas. They vary. And one of the claims often is that ADHD is often used to target disruptive young Black males. And almost every single study actually suggests the opposite, that we are underestimating, undertreating, underidentifying ADHD among African American males in the United States of America. So again, a quick video, maybe giving them more information. The other thing, and I mentioned, I single this patient out often. I had a patient who came to me in his 50s. He came in for anger management issues. He was a bright, creative guy. He had started 3 different startups and they were successful, but he essentially lost control over them with battles with his co founders or people who stepped in afterwards. He noticed he was sort of in an argumentative, defensive crouch again in this third company he had started and didn't want to repeat that pattern. And again, although he came in for anger management, had never been treated in his life during the first evaluation. And I usually take a 2 hour evaluation time to delve into these things. It was pretty apparent to me that he had a range of ADHD symptoms. I presented this to him and he was sort of gobsmacked. It didn't make any sense to him. He didn't know anything about ADHD, or the little tiny bit he knew didn't seem that it fit him. And in his mind, this was how he was presenting, was just a reaction to the stressful situation he was in. So I suggested he talk to his family members and see if they agreed. And even though he was in his 50s, his mom was still alive. I think 6 or 7 of his siblings were still alive, and all gave him feedback. And they said, no, this is exactly how you are always impulsive. You were always blurting things out. You're always cutting people off. Yeah, you were smart, so you got away with it, or we didn't mind as much, but you were more active than any, hyperactive. So he had a whole range. So part of it is, people with ADHD aren't always the best historians. They might have not even recorded the information accurately while it was going on. All of us have some challenge or difficulty figuring out how the world sees us. So that's a barrier. And again, people who are smart enough and not disruptive can get by with a lot. So I've had several doctor colleagues, some of whom I am completely convinced because I worked intimately with them, that they have ADHD, who, again, very bright people, didn't ever have a diagnosis, and then we're asking in their 40s or 50s, hey, could I have it? No, I couldn't possibly have it. I couldn't have gotten through medical school if I had it. Again, it doesn't mean you can't focus. It doesn't mean you're not smart. It doesn't mean you can't succeed. Some people in my book about Donald Trump and ADHD pushed back and said, you can't say he has ADHD because he's such a successful politician and businessman. And if you have success, that means you can't have any impairment. And I'd say that's absolutely nonsense thinking. You can have tremendous success and still have impairments at the same time. Um, so maybe I've talked that one through enough. And hopefully, if the sound's any better, let me know. Yes, so one other approach with lob bond. I mean, there are certainly some doctors who shouldn't be doctors and don't like working with patients or insist that everything should be their way. I still think the majority of doctors are trying to help you get better and trying to protect you from risk or damage. And if there's any way you can find or adapt an attempt to be collaborative and working together rather than insisting, damn it, I have this and I need this medication and you're an idiot if you don't give it to me, you're probably more likely to make more progress with the collaborative approach. Doesn't always work, but you'll probably feel better from it and know that you've gotten as far as you could with that individual. Um, Max Doppler asks, hello, have I got any favorite movies? This is an oddball one and probably ties back to the era I grew up in, but so I was born in the early 60s, and every year, particularly, I think it was around not in the Halloween spirit, but The Wizard of Oz showed every year on television. It was a huge event. I really think, yes, the special effects are horrible, but I think it does a perfect job of being funny when it's trying to be funny, and there's a lot of humor in it. And it does a wonderful job of being scary when it's trying to be scary. And it has a wonderful story arc, and different people interpret the messages differently. And I think the acting, singing. So Max asks, is it possible to have ADHD without memory issues? So part of it is a difficult answer. I mean, one is clearly some people can have impairment or deficits or challenges in certain executive functions and not in others. We know that ADHD presents in a lot of different ways. Some people have time management issues that are huge, others that's minor. Um, Other people have more trouble initiating a project, some may have more trouble finishing it. So, part of what's really difficult, and I've talked about this before, probably in the dementia talks, we sort of lump, oh, dementia is a problem with memory, happens late in life, and ADHD is an attention issue. And if you are not paying attention, you're not encoding the information either at all or as well. Even if you're nodding your head and your partner is asking you, "Did you unload the dishwasher and walk the dog today?" And you're busy gaming, and you're saying, "Yeah, yeah, yeah, yeah," and then dog poops on the carpet, and she screams at you, and she said, "Why did you tell me you had?" And you say, "I didn't tell you that." So it's hard if you have attention problems or to not have some at least occasional incidences where you're not encoding things properly. And again, that's may not be an impairment in the memory system itself, but it's a impairment in what gets loaded into the memory system. So I'll say it that way. Um, Again, one of the most impressive studies, it's part of the Dunedin, and I may be pronouncing it wrong. It's the longest or one of the longest ongoing, um, not just psychiatric, but other social psychological studies started in New Zealand. But they have among their cohort were kids who were diagnosed and treated, and again studied when they were younger, verifiably had ADHD. And I don't have the statistics right now, but it was more than 40%. It might even be more than a majority, 60% of them, when they were questioned in their early adulthood, early 20s, said, "Oh, no, no one ever told me I had ADHD. Nope, I was never treated for ADHD." It doesn't seem that they were hiding because of stigma. It doesn't seem, but it also seems impossible that they weren't told, they weren't remembering putting, I mean, maybe they didn't really remember putting the drugs in their mouth every day because that just happened every day and that was the way life was. So whether you think you have memory problems or not may not even you may not even be the best one at assessing whether you have memory problems. So memory problems are not, I mean, of the 9 inattentive DSM, I mean, certainly not one of the 9 um, impulsive hyperactive behaviors. So of the 9 inattentive, I mean, there is one about losing things. Is losing things technically, you would say, have to be about forgetting because you placed it somewhere or left it somewhere and can't remember? Yes, but it's an indirect. So none of the 9 are directly confronting memory head on. Um, so again, whether memory is impaired is not a central aspect of the DSM criteria. Yeah. So Laban is adding, I successfully poured my orange juice into my coffee again. And I would focus on the again there because probably all of us have done something like poured the orange juice into their coffee, poured the coffee into the breakfast cereal, left the coffee cup in the refrigerator when you went to get out the cream, something like that, occasionally. But if it's again, if you're laughing, oh, I did that just last week or last month or something like it every day, then then it's much more suggestive of being in the ADHD realm. Um, so, did sound get any better at all after I did something about 10 minutes ago? Um, so I see it. John Tay has a question coming in, but two questions for you guys out there. One, did sound improve at all? And two, I've gotten feedback that because of how YouTube algorithms work, and that there seems to be more people who observe my videos a few hours earlier in the day and wondering if I switch the Q&A. So it's been at this current time, Hawaii doesn't switch time. The rest of the world mostly does. So this time is, I'm going to have to look at the clock over there. Um, right now it's 12:40 in Hawaii. That means 2:40. So I've been starting at 2 o'clock Pacific time. But there's some suggestion that if I move 2 hours earlier or even 4 hours earlier, that may get more people or bigger audience. Are any of you strongly opposed to moving it any earlier or don't particularly care? Or yes, it would be much more convenient to have it earlier. So that's a question for you. And then so John Tay says, I've talked about the importance of learning to switch out of stuck states, and I do have a video on that. I'm wondering if this can also be applied to switching out of depressed slash anxious states. So particularly, I also, you might have viewed it already, but I do have a talk about viewing anxiety as an attentional problem. So I would think almost always you can train yourself to learn cognitive behavioral techniques to help yourself switch out of anxious states. And at least in the short term, so the difference being with anxiety, yes, some people are chronically anxious, but often, I mean, almost always, there's huge ebbs and flows in intensity of anxiety, and it's the overwhelming. I mean, some people are bothered by the chronicity, but more often it's when it reaches a certain height. And yes, I think most people can learn to switch out of that anxious state because it is, in some ways, a problem of attention. The problem is you're focusing on how you're performing, how others you think are observing you, or what you imagine a danger is going to be, and you're not actually engaged with the world as it is around you. Usually, if it's anxiety. Now, if it's fear, if you're really in the middle of a burning building, you should be scared and you should be doing something to get out of it. Depression, I think the cognitive skills are also important and valuable, but whether they are bringing you just a short reprieve or a longer term reprieve, although I would say the more you break up or may that you get out of depression, the easier it is to continue getting out of it. So, so Lab's experience as a sound is a lot better. Good. Moose asks, do I think there's a relation to careers like software engineering and ADHD diagnosis? Um, for example, continued abstract concentration in front of a screen all day. So the cliche is that lots of programmers are either somewhere on the autism spectrum or ADHD spectrum or both. Um, I don't know that anyone's actually conducted a study or survey to demonstrate that's actually true. And part of it, even depending on how you did the study, it would be hard to observe because I think there is more awareness of ADHD among the, and this is sexist, but particularly the sort of the software bro programming crowd. Um, so there may be greater endorsement of it, even if they don't. I think evidence is pretty robust that lots of interaction with a screen environment can enhance certain aspects of paying attention and also is disruptive to maybe more global ability to switch attention, to sustain attention without being distracted, um, working memory, other things. I mean, so screens aren't all bad. And this is to paraphrase Ed Hallowell, the author of Driven to Distraction. I don't know if he still does, but in his earlier days, he would end almost all of his lectures with, and he strongly supported the use of medications and how helpful they can be. But he'd say the most important thing for someone with ADHD is finding the right career and finding the right partner. Um, those are important for everyone, for positive, fulfilling, joyous lives, but they are more important to people with ADHD simply because people with ADHD are less able to create the structure they need for themselves. Um, and it's not just structure, but interest and motivation. So it's certainly conceivable to me that people with ADHD are more attracted to certain careers and that there may be feedback loops. If the whole industry is biased a certain way, then their managers or other people around them are more likely to be behaving in a certain way and reinforcing certain behavior. But I'm not aware. It may be. I just don't know of any rigorous research on that. So Max noted he used to be very sensitive to caffeine, but now it seems they're less anxious while drinking. Um, Many people do develop tolerance to caffeine. I do have a talk on caffeine here. The sleep experts, most of them would put it as enemy number one because it's basically undermining the adenosine system, which is the clock or the reminder of how long it's been since you slept last. Um, and on a dose per dose basis, and I mean equivalent dose for how much it helps with attention, concentration, executive functions. Caffeine, even though it's the most ubiquitous stimulant on the planet and many classify as the most ubiquitous drug, is also more dangerous. I mean, effectively, we're usually using it at much lower doses, but it seems to have more cardiac toxicity, more anxiety when used at an equivalent dose compared to our heavy duty controlled stimulants. And those are generalizations and averages, and certainly individual results may vary. So, Jante, and again, if I'm butchering your name, you can try to help me pronounce it in the chat or just let it go at that. Um, Only diagnosed with ADHD 4 months ago. The medication is helping, but still have problems with emotional instability at times. So, without mentioning which medications, there is some well done research. Russell Barkley was involved in some of them, indicating that people who got good cognitive attentional responses to ADHD medication, specifically to stimulants, often had improved emotional stability and emotional regulation abilities. So, again, which makes sense if all of these are executive functions that are occupying the same piece of real estate and there's some amount of spillover, continuity, crosstalk between and among those. Certainly, though, one of the side effects some people experience with stimulants is it can make them, particularly if it's too high a dose, that can make them more irritable. It can make them more emotionally volatile. So, one question maybe, and again, I'm not making a specific recommendation, but if you were working with me, we would almost certainly be experimenting with dosage, and it might be either going up or down, depending on what other information you had. But if you're not in the optimal spot, you may be treating some symptoms of ADHD and not others. I mean, it's also possible that for you, they will work better with one set of aspects of ADHD. The two other things I'd say are that, in particularly, um, Driven to Distraction was one of the books that strongly promoted stimulants. And I think many people are backing away from a little bit of this, but 20 years ago, many people would read a book like that and get the impression, oh, all I need to do is take Ritalin or Adderall and it will cure all of my ADHD. I like to explain it that from what I see or know, ADHD is at least as much about wiring as it is about neurochemistry. And yes, the neurochemical pushes can certainly help a lot, but they're certainly not immediately rewiring the brain. And I haven't met anyone who had complete elimination of ADHD symptoms from medications. I've had many people who functioned much, much better both at work and in home life, who could complete schooling, finish a job, get promotions, maintain a relationship that they couldn't do before. So I think medications can be powerfully, wonderfully helpful, but they never help all of it. The other thought is depending on, and different people can mean different things by emotional stability or instability. It's possible that guanfacine helps some people feel as calming or stabilizing on an emotional level. So Diane C says, hi, hi. She's newly diagnosed and taking methylphenidate, instant release, and bupropion. Is generic Focalin instant release worth trying? Substituting for methylphenidate, immediate release. So again, I'm so I have to answer this as in a generic way, not a specific recommendation way. What I can say is there are now more than a dozen different formulations of different combinations of methylphenidate, um, looking at dexmethylphenidate, looking at racemic mixtures, equal amounts of left-handed and right-handed, looking at combinations that have different amounts of short and long acting being released at different times. My experience is that most of the differences within that class are minor tweaks. I mean, I think Journay is substantially different. That's the one with the 10 hours before it's released, so you can take it at bedtime. I think Datriana patch is substantially different because it's for people who can't tolerate or won't tolerate taking drugs orally. It applies to the skin. But my experience has been, even though there may be clear neuroscience explanations or reasons why. So I do see significant differences between instant release and extended release formulations of the stimulants. But and I've certainly had some people who said, oh, Focalin worked much better than Ritalin long acting. Concerta worked better than either of those. And I've certainly seen people who prefer different agents, but I don't see big systemic advantages for any specific product. Again, I do have many people think who experience more steady response and less often on phenomena with the long acting. And of the long acting, Concerta has been far away the methylphenidate product that I've heard the most positive feedback, but that's not for everybody. So I think I answered that. So Moose asks a question that no, I haven't directly addressed that. So the question is, how come taking ADHD meds can make them feel no desire for alcohol or other recreational substances some days, but not all days? Um, I mean, one, our desire for substances is subject to lots of different factors. I'll back up. We know that ADHD, even people completely unmedicated, not just changes at different points in life when more or less structure, more or less demand is there, but changes on a day to day basis. So many people with ADHD will wake up in a bad or discombobulated state and know that their brain is, to put it colloquially, shit the whole day. Other times they wake up, and again, this is without medication even, will say, I just woke up. I was in the zone. Things were flying. I was productive all day. I wish I could have every day like that. We know that one factor contributing to severity or intensity of ADHD symptoms the next day is how well you slept. But clearly, there are lots of other additional factors we haven't identified. So, again, that's there with ADHD, even before medication gets added on. So, when it's there, when medication is added on, is it just that you're noticing it more because some of your executive functions are working better, or it becomes more salient what that difference is? Um, the stimulant, sorry, in addition to executive function and cognitive functioning benefits, the stimulants also have an effect on mood. So if you're feeling happier or content on a given day, maybe your body processed it differently, or um, then that could diminish or take away any desire for alcohol or recreational substance. Maybe being in a more productive mode and seeing that you can succeed, or enjoying your work and enjoying your colleagues for a certain number of hours puts you in a very different state when the possibility of recreational substances pops up. So that's a vague answer, but that's the best I can do. I'm seeing them getting close to time because I'm trying to keep these to an hour, but I'll hopefully go through the next. So, hello, Mr. AKA. Fluvoxamine, Luvox alters caffeine, pharmacokinetics, but not pharmacodynamics. Do you know why? Should people on fluvoxamine and others C1P, 1A2 inhibitors limit caffeine intake? So, pharmacokinetics is how your body processes the drug, and pharmacodynamics is how the drug works on your body. And the claim here is that so fluvoxamine is a serotonin reuptake inhibitor. It is an inhibitor of the specific liver enzyme CYP1A2, which some drugs, such as caffeine, it's important for metabolizing them. So what this is saying is that Luvox should affect caffeine levels, but it's not affecting how caffeine affects the body. I mean, part of it may be that even if it's affecting the amount that's present at any given instant, that amount is still within the range of what is or above a sub-threshold amount for caffeine to have its effects on your body or the bodies that are being tested. So Diane asks again, any advantage to Focalin over Ritalin? And again, if we're talking about Focalin long acting versus Ritalin short acting, I'd say that's a bigger difference. But in terms of short, comparing short to short or long to long, in general, I haven't seen any substantial difference between those products. Laboon Spawn says, I know a third party who uses over twice the recommended max intake of nicotine replacement products. Aware of any theoretical neuropathway of nicotine in people with ADHD, downstream dopamine? So I believe I have it, a talk on nicotine and ADHD in this on this channel. It's one of the older ones. Um, there were pharmaceutical companies trying to bring nicotine acting agents to market for specifically treating ADHD. I'm not sure why those were abandoned. So, and again, in relative to my talk on high doses of any medication, to me, what's important is what physiologic effect is that having on that individual? Are we seeing whatever benefits we wanted? Are we free of whatever side effects we may be afraid of? If that's the case, then I wouldn't worry that much about the dose, particularly if you're not smoking to get the nicotine. Yeah. And Diane C, and I looked at, I mean, there's a tiny bit of research on people who've had bariatric or other surgery. And my distillation of what's said there, and your doctors may be not comfortable or not willing, is that it's not actually an absolute contraindication. It's that it's in an individual's results may be highly unpredictable. That doesn't mean they would be varying tremendously day to day. They may actually be more consistent day to day, just because you have less of a convoluted, lengthy digestive system to be dealing with. Um, so it may be that a very cautious approach to a extended release may be a helpful approach to try. I will putting that out there as a general informational recommendation. Hey there asks, would it be a good idea for someone on lisdexamphetamines or Vyvanse and generic versions of it to take tyrosine supplements? It's unlikely to be highly dangerous. Again, often, and I'm not aware of any specific research of tyrosine supplements and any ADHD medications. I will see if there's enough on that or anything. But one of the important things is if a shortage of tyrosine is not primarily isn't the rate limiting step, and I do have a talk on rate limiting steps, I believe, then taking more of it orally just is irrelevant rather than so it takes you have to absorb it, you have to get it across the blood brain barrier, and it has to be again what is causing a shortage in the manufacture of dopamine or norepinephrine. And if that's not where there's a delay, taking more won't help. It's sort of like if you have a big Ford factory turning out, I don't even know what model car, and you'd say, oh, that assembly line's too slow. Let's boost the number of left hand driver side doors that are being fed into this assembly line. You may be, yes, driver side door is an important part of the finished product. Yes, it's essential. But if that's not the rate limiting step, flooding the assembly line with more doors is not going to make things go through the assembly line faster. So I'm trying to wrap up. So if there's yeah, and I would say there is some evidence that methylphenidate may have less potential for addiction than Adderall, amphetamine products. Again, though, some of the best research on individuals with ADHD doing better in rehab or sobriety used um, Vyvanse, Dex, lisdexamphetamine, finding it generally safe and again helping with sobriety. Yeah, and again, I'm talking more about tyrosine. If if they're not having a nutrient deficiency, I mean, a general purpose, broad spectrum diet seems to be a way to better health for most individuals. So I'm going to end it there. I see a question on citicoline, um, and I can't say anything intelligent on it in a second, so I'll put that one off. So again, any quick, if I move this Q&A to 2 hours earlier or 4 hours earlier, any strong feeling or feedback? Um, and if not, I will be signing off and wishing people a happy election day and a happy. The thing I will remind people is whether the outcomes are what you exactly hope for or what your biggest fear or dread are. And I do think there are substantially different scenarios or pathways that could start the United States on in the for most people in most of their lives and most of their day-to-day living will not change dramatically, particularly in the next days or weeks. So try to hold on to the longer picture, even if you think it's a bad picture for right now. Stay healthy, stay happy, and that's all for now.